Hi, my name is Mahesh Ramachandran. I'm the Chief Medical Officer and a physiatrist at Marion Joy Rehabilitation Hospital, part of Northwestern Medicine.
Hi, I'm Padma Raju. I'm a physiatrist taking care of neuromuscular patients here at Marion Joy Rehabilitation Hospital. So here at Marion Joy, we've had wonderful opportunity to treat one of the first COVID lung transplant patients.
I think one of the most surprising aspects of his clinical condition was the extent and loss of muscle mass that he had experienced being immobilized for such a long time and in bed. The deconditioned state that the patient had, we had to tailor the therapy in a much different manner than a typical rehabilitation patient. The intensity of therapy had to decrease because he would not be able to tolerate the typical intensity that we have in an acute rehab patient. We had to watch parameters such as the oxygen level, the heart rates, and the blood pressure. And as the parameters got better, the vital signs got better, then we were able to advance and increase the therapy for the patient.
One of the unique considerations or challenges in treating the patient after he arrived is the anxiety associated with having the infection itself in the middle of the pandemic and the severity of the infection that ultimately led to double lung transplant. Oftentimes, patient would say that these are not my lungs. So that tells me that he didn't have time to process what had happened in the acute care. The other unique challenge is not being able to have family by them through this prolonged sickness. That's a huge emotional factor that plays into his recovery, which also has an impact on his physical recovery. In addition to that, being on lung transplant means that you have to be on multiple medications, and especially anti-rejection medications. And it's very difficult to tolerate these medications. So emotionally, it's the fact that he has to take so many medications, and also physically, they cause a lot of nausea, tremors, and some other side effects. And these are more amplified in the setting of a profound muscle mass loss due to prolonged sickness and being bound to bed for such a long period of time. These have been huge challenges for us to work with the patient. Oftentimes, physical therapy and occupational therapy had to work with ongoing education in terms of diaphragmatic breathing, so in order to address his anxiety.
For patients with COVID, there are multiple manifestations that we were finding. You have cardiac problems, you have neurologic manifestations, you have hypercoagulable states causing clots and strokes, nephrologic problems or kidney problems as well. And this particular patient had all of those.
These patients typically have very poor cardiopulmonary endurance, which need to be monitored through oxygen saturations and vitals, because they often need multiple liters of oxygen, and also their heart rate will jump up quickly even with very minimal activity. So this is a huge consideration before we accept a patient into a rehab setting. Up until now, patient has been battling with his low endurance, which he is actually now beginning to improve. He will be starting 0G, and we are hoping to continue to use our advanced technology in order to further assist patients' functional independence. In the length of stay of 4 weeks, the progress in terms of ambulation has been slow, so I predict a patient not being able to return to complete normalcy anytime sooner. It might take several months, even up to a year. So I predict the recovery is going to be slow, but definitely gradual, but there will be good recovery.
And so we have a team that is looking at all aspects of the care, looking at the progress, looking at what we're doing well, where we have opportunities to help even improve and get better. Based on the patient's progress, we feel that we're doing a very good job, despite the unique challenges. But moving forward, we think that we can make some tweaks to our program to for the next patient to make it even better for them.